Pregnancy and childbirth is a very powerful and a miraculous journey, but it inherently places a woman at risk during childbirth because of profound physiological demands. Hello, everyone, and welcome to Birth Vibe by Birthright Rainbow Children's Hospital, where we share pregnancy related insights. Today, we are going to discuss a very important topic that weighs on so many families, and that is blood loss during pregnancy. We will emphasize on this topic specifically related to the placental related conditions. We will understand what is the role of blood transfusions in such cases. And it will also be interesting to hear from our expert about the newer blood conservation strategies. I am Dr. Annie Pranutha, consultant obstetrician and gynecologist, team Birthright. Joining me is Dr. Surekha, who is our esteemed transfusion medicine specialist who leads our blood bank services and also who has saved countless lives in this journey of hemorrhage crisis. Dr. Surekha and her team are the unsung heroes here who manage and meticulously plan the transfusion services and make our job effortless and also for the families providing comfort in their journey. Welcome, ma'am.
Thank you, Dr. Annie. I'm happy to be here to discuss this crucial topic of transfusion support during obstetric hemorrhage.
So, ma'am, let me start with the basics which the families worry about, and that is blood loss during delivery. So it's very imminent that during delivery, at the time of placental separation and post that, even in normal cases, there is blood loss in a normal vaginal delivery for about 300 to 400 ml. And in a planned cesarean section, in a routine cesarean section, also we see blood loss of about 600 to 800 ml. But when we are talking about the adherent placental conditions, the blood loss can skyrocket to 2 3 liters and 3.5 liters, and that converts a planned surgery into a profound emergency situation, worrisome for the obstetricians, our critical care team, and also for the families. Madam, will you just enlighten us on the importance of blood transfusion in this case? What are the blood products that needs to be transfused in such cases, and what is the role of each component?
Coming to the blood components, the whole blood donated by the donor, we convert into various components like packed red blood cells, fresh frozen plasma, random donor platelets, and cryoprecipitate. Each component has a significant role in controlling the bleeding during hemorrhage. Packed red blood cells are used in treating anemia and they increase the oxygen carrying capacity to the tissues. Fresh frozen plasma has abundant all the coagulation factors and they control the bleeding when the patient is in coagulopathic bleed. And random donor platelets or single donor platelets also we have the facility to process single donor platelets. One single donor platelet concentrate is equivalent to 6 random donor platelets in terms of platelet yield. So we give either of them during emergencies. And platelets control bleeding due to thrombocytopenia, that is when the platelet count drops to less than 50,000. And cryoprecipitate has abundant fibrinogen. It controls the bleeding due to low fibrinogen levels. That is when the fibrinogen drops to less than 100 milligrams, then this cryoprecipitate helps to control the bleeding. And these components also prevent important complication called disseminated intravascular coagulation when they are given in the collective manner during major blood loss. And during high risk pregnancies, when we are anticipating major blood loss during cesarean section, then we gear up for massive transfusion protocol during antenatal period itself. So we call the patient's family, we tell them to mobilize donors, we counsel them, and we tell them the importance of transfusions during major blood loss, and we tell them to mobilize some donors beforehand. And we always maintain sufficient inventory to meet any emergencies during obstetric hemorrhages. And if at all we anticipate any major blood loss, that is massive hemorrhage, we announce a massive transfusion protocol. That is, we follow the protocol of 6 is to 4 is to 1 in a center. For every 6 units of red blood cells, we give 4 units of fresh frozen plasma and 1 unit of single donor platelet concentrate or 6 units of random donor platelets along with 10 units of cryoprecipitate. If the blood loss is controlled, then we stop the transfusions here. But the triggers which we maintain during massive hemorrhages. Hemoglobin should be maintained above 8 grams. Platelet count should be maintained above 75,000. INR should be less than 1.5, and fibrinogen level should be maintained more than 1 gram. By maintaining this, we are preventing some complications of massive blood loss, that is acidosis, coagulopathy, and hypothermia.
That was very informative, madam. Thank you so much. So, when we talk about this massive transfusion protocol, so when we know ahead of time that there is an adherent placenta and we are planning surgery, can you tell us how we as obstetricians can coordinate with the blood bank team prior to planning such surgeries so that we can optimize the entire outcome for the woman?
That's what I mean. We first educate the patient's family, then we maintain sufficient inventory. If it is patient's blood group is a red group, then we mobilize donors beforehand and we keep sufficient inventory of the red blood group red blood cells in our inventory, and accordingly we prepare in our. Please encourage your patients to mobilize donors and encourage voluntary blood donation, because blood is something which cannot be manufactured. Unless they mobilize donors and donors come and donate blood, we cannot process blood components and meet the transfusion requirement of our patients.
Yes, ma'am, exactly. So here I think counseling becomes very, very important because planned surgeries, at least when we are planning a delivery for an adherent placenta by C-sections around 35 to 36 weeks, it's very important that we counsel the families, encourage for the donation, and also coordinate with the blood bank team so that adequate amount of blood is reserved and we don't run from pillar to post at that time. Madam, also I think it's very, very important that women are more proactive in maintaining their hemoglobin, taking iron supplements, and also important for the obstetrician to screen all these pregnant women for iron deficiency anemia. Because when I'm hearing massive transfusion, it's very important that these women enter into this pregnancy and at the time of surgery in a best possible health condition, ensuring that the hemoglobin levels are above 11.5. So treating iron deficiency anemia in this case with oral or parental iron, whatever is deemed necessary, if we maintain the hemoglobin above 11.5 and 12, this will help them to cope up the blood loss in a better way during surgery, reducing the requirement for blood transfusions. And not only that, it might also help in postpartum recovery of such women. Yeah.
So
So,
augmentation of hemoglobin is very necessary during antenatal period itself. As you said, it even there's massive loss also. There might be some amount of transfusions, but not massive transfusions.
exactly, madam. So, this patient blood management, I wanted to say that it's very, very important. Also, one of the things about this patient blood management, they say, is apart from optimizing the hemoglobin, other one is minimally invasive surgery. So, cesarean section can never be minimally invasive. That's what surprises me. So I think it's a very good time for us to also encourage women to take care of their own health, be responsible for their health, and enter this pregnancy journey with the best possible health condition. So coming to what about the concerns around the blood transfusions, madam? Most often families are concerned about the safety issues. So are there any precautions or safety checks that you do prior to issuing blood
Yeah,
for the
we
patient?
follow all the precautions or safety measures for blood safety in our center. We screen all the donated blood units for various transfusion transmitted diseases like HIV, hepatitis B virus, hepatitis C virus, malaria, and syphilis. And we also do the nucleic acid testing for all the donor units. This further increases blood safety because it narrows the window period of these infections. This is an additional layer of blood safety. And for all PRBC units, we do the leukoreduction, thereby minimizing the transfusion reactions like febrile and allergic reactions. So we follow the concept of universal leukoreduction of PRBC. And we do the compatibility test or cross matching test between the patient sample and the donor unit to see whether the patient sample is compatible with the donor unit. And we also check for the antibodies both in the patient as well as in the donor units also.
Yeah, so this is very, very important, madam, to have a documented report of blood group and RH type, and also to test, especially in this high risk women, to have a antibody screening for us to identify any circulating rare antibodies. So, madam, in these cases where tricky ones, which have rare blood groups, or where there are cross matching issues, madam, what are the options that are available?
Like if we find an incompatibility unit, like even if screening all the blood units in our center, we get an incompatible unit, then the best option is to go for autologous blood transfusion. Since for pregnant women we cannot do pre-operative autologous deposit, so during intraoperative stage we have some measures for intraoperative autologous transfusion, like intraoperative red cell salvage. For this we require a machine called cell saver. So intraoperative cell salvage is safe and recommended method in obstetric practice, particularly for women with adherent placenta, where there is major blood loss. So, whatever the blood lost, that is the shed blood, is collected by suction in this cell saver, and this blood gets mixed with an anticoagulant solution. It is filtered. Later, it is washed with saline and undergoes centrifugation to get a concentrate of red blood cells, which are collected in the blood bag, and that is reinfused back to the patient. And this is a continuous process. Whatever the blood lost is like recycled, then it is reinfused back to the patient after all these steps. During this process, the plasma and platelets, they get expelled in the waste bag. The patient is receiving only the red blood cells back, and we have to supplement the patient with FFP, that is fresh frozen plasma and platelets, from a blood bank inventory. So the anesthesiologist and the obstetrician should keep this in mind by monitoring the patient either by point of care testing like ROTEM or by lab tests. They have to check the INR, platelet count, and fibrinogen levels. And if they drop, then we have to supplement the patient with FFP, platelets, and cryoprecipitate to prevent coagulopathy in the patient.
Okay, so that is a
And this
very,
is a continuous process, and it's an automated process also. The machine does all these steps.
yeah, so that was very interesting to know, madam. When we talk about cell salvage, are we looking at any advantages that it has over a donor blood
Yeah,
transfusions?
definitely. Since this is an autologous blood transfusion, it minimizes the risk of transfusion reactions and also disease transmission. And it provides red cells, that is, they are more fresher than the bank plates, so that has better oxygen carrying capacity, and it is cost effective for the patient. And it is a blood conservation strategy and an important component of patient blood management.
Okay. So let's say, madam, there is no cell saver. Then what next? Do we have any alternative in such cases?
If there is no cell saver, there is another mode of autologous blood transfusion during intraoperative stage, just before starting the surgery. That is at the time of induction of anesthesia. Uh, at least 1 or 2 units of whole blood is collected from the in a blood bag. But for this, the patient should maintain adequate hemoglobin level. At least the hemoglobin should be more than 11 grams or 11 grams. So 1 or 2 units can be collected safely, but this is whole blood, and this is stored in the theater or in the blood bank with the patient's label on. And we have to mention this is for autologous transfusion. And later, the hemodilution is induced in the patient by infusing crystalloids. That is, a stage of hemodilution is created inside the woman's circulation. And towards the end of surgery, these 2 units are reinfused back to the patient. But this is done only when massive blood loss is anticipated. That is, when blood loss is more than 500 ml, then this autologous units are collected and then reinfused back to the patient. The advantage of this is called ANH, or acute normovolemic hemodilution. The advantage of blood in this case is since this is transfused within 6 hours after collection, the platelets are viable, the coagulation factors are present, and even hemoglobin levels are increased. That means it provides all the three components. Whereas in cell salvage, only the red cells are being salvaged. So that is the difference between these two mode of autologous transfusions.
Thank you so much, ma'am, for demystifying this very important and a difficult topic for all of us to understand. And I'm sure even the families hearing this will also be feeling empowered, and they will be able to mitigate all the concerns that they have about the blood transfusions. So, for the listeners, I would like to tell that, especially for the women, it's very, very important for you to be empowered and also optimize your own hemoglobin health. And you should also be aware that there are options like cell salvage, which is a newer intervention, and that will remove the all the fear and the concerns that you have about the blood transfusion. So I'll say that continue to tune in to Birth Vibe by Birthright for more pregnancy insights. Thank you so much. Stay informed and stay safe.